So telehealth is amazing. Research is enabled by being able to access electronic health records in many different ways. And it enables patient engagements. Our patients have a much easier time now of seeing their own data and the information about themselves. Next slide, please. So he couldn't be with us today, but Gordy Schiff and his colleagues have written some amazing articles on this topic. And these are the best of the lot. So I would recommend both of these references. They're both authoritative and have very rich discussions of the things we'll be discussing today. Next slide, please. So today we will be talking about 3 new ways that health IT can improve diagnosis. And these are all novel. None of these existed a decade ago, or they were just coming into being, and we certainly couldn't do these with paper charts. So first we'll hear about new decision support tools and how they can improve diagnosis. There are many such tools out there now. Some examples are DXplain and Visual DX, and we'll hear in more detail about the Isabel system from Jason, who developed it. Hardeep Singh will tell us the Trigger Tools story. These are software algorithms that can help detect cohorts of patients who are at increased risk of diagnostic error. And Michael Cantor will describe the Safety Net program he's established at the Southern California Kaiser Permanente system. And this is software that helps prevent the harm from breakdowns in the diagnostic process. Next slide, please. So let's get going. Our first speaker is Jason Maugg. Jason was actually an investment banker in the UK when his daughter almost perished from a diagnostic error. And he's devoted his life since then to helping us prevent diagnostic errors by developing a fast and easy online resource and a system he named after his daughter, Isabel. So Jason has had firsthand experience with diagnostic error, and through his work with the Isabel Healthcare Limited, he has developed this product that we'll be learning more about. So Jason, thank you for joining us. The title of his presentation is Health IT to Enable Differential Diagnosis.
Thank you, Mark. Look, what we're about, as Mark said, is really using how online diagnostic decision support tools can help at the very early stage of the process. So it can help not only clinicians, but increasingly now help patients research their diagnosis and think about it and talk to clinicians. Can we have the next slide? So it started, as Mark said, with a story. You probably noticed in my bio there was no IT background and no medical background, which seems unusual. So it started purely from circumstance. I was in finance. This is a picture of me with Isabel, who fell ill when she was 3. She had chickenpox, and she developed other symptoms such as fever, diarrhea, and vomiting. And we took her to a local primary care and the local emergency department, but every symptom she had was shrugged off as normal chickenpox, essentially until it was too late. And she went into multi-system failure and was diagnosed with necrotizing fasciitis. So she ended up spending 3 weeks on intensive care, and this picture is her still 2 weeks into intensive care, as you'll see with a number of lines coming out of her. And it was there that the clinicians actually said to me, you know, you guys weren't very well looked after. And that planted the seed of what happened, of primary care clinicians trying to pick out the unusual illnesses such as Isabel, or when we go to the emergency department, you're seen very much, particularly in the UK, by junior clinicians who are not very experienced and unable to recognize these very unusual diseases. So I thought really what was needed was a tool where if a clinician had a doubt, all they had to do was type their signs and symptoms into a computer, press a button, and could get a list of possible diagnoses. So that was the original inspiration, and that was back in 1999. Next slide. So modern medicine is good and managed to pull Isabel back from the brink. And this is just a few pictures so you can see today, how she's changed from that 3-year-old. In fact, on the left-hand side, you can see her pictured with Barry Markowitz, who's an intensivist at Children's of Los Angeles. And then just a few weeks ago, she was in Tanzania helping in the school and actually recently climbed Kilimanjaro. So modern medicine is wonderful, but shouldn't have let her get to this particular stage. Next slide. So who we are today, we're a company today, but we actually started in 1999 as a charity. At that point, I was essentially a very annoyed parent, and we decided to start building the tool on a charitable basis, as we thought that would reduce the friction for people to use it. It was available for about 3 years on a free-to-use basis, but we found it wasn't sustainable, and so had to convert it into a business in 2004. So today we are a business, but we are a third owned by a charity. So I would describe ourselves more as a social enterprise. And I think today we are the leader in diagnosis decision support tools for both clinicians and patients. Patients we added more recently in 2012. And our main user base is actually in the US, where we have about 100 institutions using the tool, varying from primary care practices to children's hospitals to community hospitals, right up to academic medical centers. We also now have clinics in India. We're starting to work in China. So it's been used on very much a global basis. Next slide. So this is a picture of the problem we're really trying to fix here. It's about helping clinicians recognize disease in time. And I think from my experience, healthcare sort of divides the problem up into there's a problem with early diagnosis in cancer, or there's early diagnosis in dementia or stroke, when really it's exactly the same issue, whatever the disease is. The only difference is time. So whether it's Ebola, whether it's cancer, whether it's necrotizing fasciitis, or whether it's a urinary tract infection, it's about recognizing the disease in time, recognizing what that pattern of symptoms could mean in time before it's too late. Because I know from my own experience that once you've left it too late, the consequences are dramatically different, and the costs of care are dramatically higher. So this is really what we're trying to fix here, is help people think about a disease before it's too late. Next slide. So this is where we see diagnosis decision support tools actually fitting in the whole process. Obviously, all of this is very simplified, but down in the bottom left-hand corner, you've got the patient that's just presenting with symptoms. All they know is they've got symptoms. So our tool is designed to help them decide how important the symptoms are and where they should present. Then, of course, they present to their primary care clinician or to emergency care, and then those clinicians are faced with the issue, is this something I can deal with? Is it something serious? Or do I need to refer to a specialist? And if I do need to refer, which specialist out of the probably 150 specialists there could be? I think if you look at the maths, you understand where the problem is that most primary care practices will only be dealing with probably 200 or 300 diseases. Therefore, their challenge is, if it's not one of those 200 diseases, and of course you're still expecting them to recognize the atypical presentations of those 200 diseases, but if it's not one of those, then how do they know who to present to, the right person that's looking after the other 10,000 diseases? So I think it's a real challenge, and I think it's unrealistic to expect clinicians without tools to remember how all these diseases present, and therefore do this effectively without decision support tools. Next slide, please. So these tools have been people have wanted to do them ever since computers first almost came useful in the 1970s. So the first tools to appear were DXplain, QMR, and Internist. And they were fantastic tools. An awful lot of work went into them, and they were very much designed as expert systems. But the problem essentially today is they were built using technology that became available in the 1970s and 1980s. So they were very structured, they're quite labor intensive, and it means today that the problem is they're quite hard to maintain and they're very hard to integrate with other tools and tend to be harder to use because you can only enter what they have in their system. So the second technology, the second generation of these tools was really Isabel, which arrived in 2000 and is built in a very different way. Isabel is not a rules-based system, but uses very clever searching software, essentially statistical natural language processing software, and applies it to a database of disease presentations. What that means is that users can enter information in natural language. It also means it's easier to maintain and easier to integrate into other tools. We're now starting to approach what I call the third generation of these tools, which are using a mixture of not just statistical natural language processing, but also natural language processing. So natural language is where it understands the actual meaning of words. And statistical natural language is similar, but it understands the meaning, the concepts. So for example, instead of you having the person having to enter the patient's symptoms, the next generation of Isabel, as we call Isabel Active Intelligence, can actually understand a whole free text note and extract the clinical features automatically from the note. IBM Watson also talks about using the same systems, but to be fair, we haven't actually seen it working across across the whole corpus of medicine. It works very much in specialist areas such as cancer. I'd also mention Visual DX, which works with images, so it's slightly different in terms of it's not covering the great range of diagnoses that, say, Isabel covers about 6,000. It specializes more in diseases that can be seen by visually. Next slide. So what's Isabel's job is, and essentially most of these tools, the job is to come up to help the clinician generate an hypothesis. If you read a lot of the research done by Mark, Hardeep, and others, quite often when they're looking at diagnostic error, what they highlight is the clinicians should have broadened their differential diagnosis, or they should have compiled the differential diagnosis in the first place. This is obviously quite hard to do in practice. In people who've got a very short amount of time. So these tools are essentially about trying to help a clinician put together a differential diagnosis in the time that they've got. And also, with the greatest will in the world, very few clinicians can actually remember how thousands of diseases present. I'd say it's absolutely impossible. And therefore, when they are putting together a differential, without a tool like this, the pool of diagnoses they're pulling from is what's in their memory. They're from their reading, from their experience, but essentially in their memory. So with tools like this, they're then pulling their differential from a vast pool of diseases. The second job of Isabel is, once it's got a clinician thinking about a disease that he probably hadn't been thinking about, it then draws their attention to the knowledge, evidence-based knowledge about that particular disease. So again, rather than throwing lots of knowledge at the clinician, we say, when you decide you need that knowledge, then it will be shown to you. And we'll be able to show you a demonstration of how that works. Next slide. So generally, what the tool is used for is, essentially, we don't expect people to use a tool like this on every patient, but essentially where there is diagnostic doubt. And of course, that will vary from primary care. It might be 5% of patients. In emergency care, it might be 10 to 15%. But it's where the clinician has doubt that it would be used. Other areas would be a referral for diagnosis. As you probably know, referrals are quite often 30 to 50% inappropriate. So a tool, diagnostic decision support tool, can help improve the appropriateness of referrals. It can help improve the appropriateness of testing. So instead of clinicians ordering tests and hoping one of the tests will reveal the answer, these tools can help the clinician decide what they suspect, think about what they suspect before they order a test, and therefore they start to order a test for what they suspect rather than a much broader range of tests. It can also be a good way of organizing knowledge, because knowledge becomes organized around diagnoses. And of course, they're fantastic for training and education, particularly training clinicians with differential diagnosis. Next slide. We've taken the whole process of studies very seriously at Isabel. We've actually subjected the tool to studies from the very beginning in 2000, and we have now over, in fact I've lost count, it's probably 30 articles in peer-reviewed journals. They've been looking at the accuracy of the tool and the utility of the tool, and the most interesting ones are ones now that are looking at the impact the tool has on clinicians. And I think some of these are the most interesting and the most have the widest implications for healthcare. So for example, we have another number of medical schools that looked at how the use of these tools could increase the diagnostic skills of clinicians. So where today we face a shortage in many countries of primary care clinicians, a way around this is to provide less experienced clinicians, less highly trained clinicians with tools. And studies we've seen have shown that it increases the diagnostic accuracy of clinicians by over 20%. One study we did in the UK looked at the impact on referrals, and we found that in 29% of cases the GP felt they no longer needed to refer the patient and they can handle it themselves. And then when they did have to refer, they said in 36% of cases it helped them refer more appropriately to the right ologist. They're increasing now. I think there are 2 key systematic reviews of these tools, and that's a good way for you to assess the quality of the tools. And of course, they're highlighting now, particularly this one from the University of Manchester in the UK has highlighted how they think these tools are actually an efficient way of reducing or preventing diagnostic errors. Next slide. Okay, we'll just quickly go into what the tool looks like. So it's essentially an online tool, so there's no software is downloaded at the center. This is purely you switch on, so if you can access Google, you can access Isabel today. This, for example, is you can see the clinician has to enter the patient's age through, they have an age bands and the gender. And in this particular example, this is a real one from one of our sites in an emergency department. They were dealing with a patient, a 50-year-old man with learning difficulties, and they were treating him for sepsis. He presented with hand edema and hypotension, as I said, treating him for sepsis, but wasn't responding. So they used the tool. They click on checklist. So if you go to the next slide. What comes up on the right-hand side is a list of what I emphasize as possible diagnoses. And you'll see at the top comes anaphylaxis, and that's what it turned out to be. And they actually told us in that particular case, they think Isabel saved that patient's life because they hadn't been thinking about anaphylaxis. The best way to think about Isabel is the tool comes up with possible diagnoses. These are ranked just in order of match, and it's the clinician's job to work out the probabilities. There's a very clear division. The tool is not there to tell the clinician what the answer is. It's there to suggest possibilities, help him think about them, but it's the clinician's job to work out which ones are the most likely and which ones he or she needs to start treating. If you click on the diagnosis you want information on, so if you go to the next slide, let's assume we're clicking on anaphylaxis. We then, in this example, go to information from Dynamed, and we come up with their monograph on anaphylaxis, you can see. So we've got the clinician thinking about anaphylaxis. Now we're drawing his attention to the information about it from Dynamed, and on the left-hand side you'll see a navigation panel with other knowledge resources, and anything you click on there will just provide information about anaphylaxis. Next slide, please. Just a quick snapshot of what third generation will look like. This is actually will be appearing in within the Cerner EMR, and here in this example it's called within the smart zone. The patient, you see they're typing in free text, And what happens is the differential from Isabel will start appearing automatically on the right-hand side. So instead of the clinician having to decide they want help, automatically a differential will be appearing in a fairly discreet way, but just gently reminding the clinician of other things he might want to be thinking about. This will be appearing possibly towards the end of the year, but what we're also finding is that within PowerNote, with some people who are using it within PowerNote, it's very, very important to have a link to the decision support, Isabel, at key points within the PowerNote. For example, where there's a section for differential diagnosis, or the diagnostic and impression section, and just having a button there is absolutely crucial to remind the clinician that it's available, and then go to the resource. So if you go to the next slide. That just brings it up more highly. And then move on to the next one. The actual crucial part of all of these tools is implementation. It's the very hardest bit. These are just 5 of the key things that I think are very important. It must be part of the institutional strategy. Otherwise, there's no point even looking at tools. You need to be, as an institution, wanting to improve diagnosis in the first place. Clinical leadership goes for everything. And I think one of the most important things is finding stages in routine care where the use of these tools becomes almost a trigger. So, for example, if you were to make a referral, then you would use these tools. Unless it's made part of routine care, then people forget they have them and forget to use them. Next slide. I just want to make a few words about the patient side now. This is some research from the New England Journal of Medicine called the Ecology of Care Revisited, and it highlights how important I think it is to get to the patient very early on. So in this, they looked at 1,000 people and looked at any 1 month, how of that 1,000 people, how many reported symptoms, decided to seek medical care, and then ended up in an academic medical center. And you can see 80% of those 1,000 people are reporting symptoms, a huge amount of them. So very important to get to them very early on. Next slide. This will show through Google, announced recently that 100 billion searches were made through Google every month, and 5% of them were health related. So that's an enormous amount of searches that consumers are making on health. Next slide. So here, for the patient, what Isabel is doing here is enabling them to build their own differential diagnosis and become informed. Essentially, we believe that the patient should be working in partnership with a clinician to build a differential diagnosis. It should be a jointly produced one. It also then links the patient to credible information, and the final stage helps them decide where to present, whether they should be presenting to their family care, their family doctor, or they could just go to their pharmacy or their drugstore and ask some advice there, or they need to go to the emergency department. And I'll show you how that looks. If we go on to the next slide. So here, this is the patient version of Isabel, which is adapted from the professional version. It's simpler to use, it has fewer diagnoses, but we've also added some functionality. And here you can see one of our customers, McNeil Hospital, community hospital in Chicago, actually puts it on their patient portal and encourages their patients to use it. And so in this example, you can see the patients put in achy joints and fevers. They've asked so that the common suggestions come up right at the top and the rarer ones down below. And you might just see on the right-hand corner there's a sort of red button with a white cross that says where now. So imagine the patient is doing this and decides they want help to decide where to present. So we go to the next slide. So here what we do is we take the results and combine them with these questions, which are very simple general clinical questions, 7 clinical questions regarding how quickly the symptoms developed, how much pain they're in, etc. And all that's combined to come up with a score presented on a dial, and the McNeil has tailored that to decide. Here you'll see the yellow says visit your McNeil primary care provider, and so that starts to help the patient very early on get them into the right bit of the McNeil facility. On to the next page. So here, this is actually a form that the patient can print out, which when we say to clinicians, would you rather have a patient come in with a series of printouts from Google and an article from USA Today, or would you rather a printout from a medically validated tool that records their symptoms, has got the patient to articulate their symptoms, and they've ticked what they're worried about? Isn't this a more productive place to start the conversation? And we're finding increasing agreement about this. So it's a real tool to help patient engagement. And I think clinicians have been missing a trick in terms of channeling the patients who are motivated to do this work, is to channel them to use tools like this that are available and get them to do more productive work. And I think they could be extremely useful. One more slide. So what's been interesting about this is that people were, clinicians were worried when we decided to make this available to patients. Naturally, people thought people would put in headache and freak out when they saw brain cancer come up. But next slide, what we found from experience, it's been out there for 3 years now, is that that's not been the case at all. In fact, very few patients are entering just one symptom, only about 12%. And if you go to the next slide, 12% are entering single symptoms. Almost all of them are entering between 4 and 6 symptoms, quite complex. And we haven't found any negative feedback from our hospital customers that have decided to make this available to patients. They've actually found it positive feedback, and they're increasingly encouraging their patients to use the tool and I think help them as well. Final slide. So just to remind you here, this is what we're trying to do with both providing the tool to both professionals and patients, is we're trying to help people recognize disease in time. And we think that's made much more possible. It's a practical tool. It's much more feasible done with the use of decision support tools such as Isabel. So I'm happy to take questions. I'm afraid that was a bit rushed, but to get through the time.
Thank you, Jason. That was excellent. This is Mark. So we have a couple interesting questions that have come in, and we have time to tackle a few of these. This one is from William Hyman. Hi, Bill. So the question is, how often is the correct diagnosis not on the Isabel list, or maybe on the 3rd or 4th screen that the clinician might not see? What is the sensitivity of the Isabel program?
Well, I would say now, I mean, that's looking at our accuracy studies in the reverse. I would say the times that it's not on the list at all is probably less than 5% now. The times that it's not on the first screen of 10, I would say would be maybe 20%. What we found from our studies, for example, we did a study using the educational cases from Medscape, where the clinicians actually asked to choose the diagnosis, so we know exactly what clinicians chose and what was on there. We found that in 80% of the cases, the correct diagnosis was the actual 1st or 2nd slot, which is incredibly good. But we decided not to publicize that because we don't actually want people to rely on Isabel. We want Isabel to stimulate thinking, and we don't want people to think that it's always going to be the number 1 slot. It's a tool to stimulate thinking, not to tell people what to do. But if you think every time you use it, 80% of the time it's going to be on that first page, I think that gives you that demonstrates a good reason to use it.
Thanks, Jason. And thanks to Mark Tannenbaum for this question, if I can paraphrase it. Are there examples where using Isabel has enabled the practice or the provider to obtain a reduction in their malpractice premium?
Very interesting. At the moment, not yet. We've had the malpractice side industries are very late to come onto this, but we've had our first malpractice insurer, MMIC, in the Midwest, is actually encouraging clinicians to use it. They're not at this stage giving a premium, but I think there would be a very good case for for an institution or facilities to ask for a discount for using it. We have been starting to talk to the underwriters who are actually based in the UK. Some of the underwriters insure the biggest hospitals in the US, and they are very interested in the idea of giving a rebate for hospitals that use it, because the cost would, one case would pay for the cost of Isabel for, if not a decade, possibly a generation.
Thanks, Jason. And this question from a couple people: what EMR systems is Isabel integrated with at this point, and how easy is it to incorporate it into a new EMR?
Well, it is very easy to integrate. We've always thought that Isabel should be integrated, and therefore we make our API available. It's integrated today in Cerner. These are in varying degrees. So Cerner, Epic, NextGen, T-System, and we're looking at many others. I would have forgotten some, but it is very easy to integrate. The main issue is encouraging the EMR vendor to integrate it, which means you telling them that diagnosis is important and you would like the tools integrated. But it's certainly integrated in the key ones.
Great. We're going to need to move on. Jason, thank you so much. Appreciate it.
Okay.
Can we get the next slide, please? And while we're doing that, let me just remind people that we welcome questions. You can submit them online. We usually don't have time to get to all of them, so we will try and answer the ones we don't get to by email afterwards. We will post the slides online. It takes about a week or two. For anybody who can't wait that long, please send me a personal email, graber.mark@gmail.com, and I'd be happy to send you the references that you need. Our second speaker is Dr. Hardeep Singh. Hardeep is the Chief of Health Policy, Quality, and Informatics Research Program at the Houston VA and the Baylor College of Medicine. Hardeep is a fellow of the American College of Medical Informatics, and in 2012 received a Presidential Early Career Award for scientists and engineers at the White House. Hardeep has been one of our most prolific investigators over the past decade. He has many dozens of articles, and they are all of top quality, looking at diagnostic error and its intersection with health IT. He co-developed the SAFER Guides for the Office of the National Coordinator and has published extensively on how to find and minimize diagnostic errors. So Hardeep, thanks for joining us. The title of his presentation is Measuring Missed Opportunities in Diagnosis in Health IT-Enabled Health Systems.
Thank you, Mark. Can I have the next slide? Thank you. So coming into this as a researcher, I think our goal is to provide a strong scientific foundation so that we can advance the understanding of this really complex topic, and look at it from the advance the understanding so that we can actually reduce these misdiagnoses. So what I'm going to do today is to talk about some of the lessons we've learned through research over the last decade in measurement of missed opportunities, and tell you sort of what are the things that we're looking at now, how we can make progress in reducing these missed opportunities in diagnosis. And mostly we've done work in the electronic health record enabled environment, so most of what I'm going to tell you today has been founded in sort of the EHR or the HIT related world. So next slide, please. Thanks. So, the key here is, I think we all can sort of relate to this. We cannot really improve what we cannot measure, but most importantly, what we quickly figured out in our research was we can't really measure what we cannot define. And so the first few slides, I'm going to talk about some of our, how do we advance the understanding of this work, and we started finding errors, through the extensive amount of research that we did in the beginning. Next slide. So what we did in the beginning was we started looking at diagnostic errors defined mostly as missed opportunities in diagnosis. I'll explain that a little bit further along. But most of our work was founded in electronic health record environments that were integrated. It's really nice to have all the progress notes, the consults, the ER visits, the inpatient notes, the secondary care information, the lab, imaging, diagnostics, procedures, all in one place, because you really have to understand the diagnostic journey across the continuum of care for patients. So the electronic health record really enables us to do that. It's really hard to do this type of research in paper-based systems because you just don't get the data because of the fragmentation of care. And what we did was we leveraged this EHR infrastructure in order to understand the diagnostic journey in more detail. Next slide, please. And what we really found was, after we did all the work, is this is quite common. There's some of the, we did an estimation, for instance, last year. It was heavily publicized, and some of you may have seen these headlines, that almost 12 million patients in the outpatient setting experience a diagnostic error every year. About half of these potentially are harmful, and that's also based out of some of the work that we've done. And when this work came out, we were sort of scared. The numbers were really scary, but it was quite surprising that many people thought that these were underestimates, which is sort of a limitation of our study. And most of the comments that we received were that 5% is the number, but it's probably an underestimate, and it's more likely to be more like 10 to 15%. This is a huge number, as you can imagine. And if you go to the next slide, what we were also finding was that it wasn't really the rare types of conditions that were getting missed. It was the common bread and butter, primary care types of issues that were getting missed. And they were getting missed because we were, mostly because of basic clinical skills, history, physical exam, ordering tests, following up of the abnormal diagnostic information, such as follow-up of abnormal test results. So, despite, clear red flags, we found that quite a few common conditions were being missed in the outpatient setting. We actually found that abnormal test results get missed about 8 to 10% of the time, even when we use electronic communication to communicate these test results within integrated environments. Something that's not on here, about a quarter of the cancer cases we looked at had missed opportunities in diagnosis. Some of you may know cancer claims often show up as the #1 reason for outpatient malpractice claims. And it was no surprise to us that about 25% of the cancer cases we looked at had some evidence of missed opportunities. So what does this work in integrated environment help us? I mean, it really helped us to better understand sort of where to focus, helped us define what we're looking at. If you look at the next slide, as researchers, we like to use a lot of conceptual models. And so this diagram really helps us sort of focus as to where we think the problems are. And so if you look at semicircle B, where there are evidence of missed opportunities, as well as harm from delayed or wrong treatment or test, which is what sort of happens when you have a misdiagnosis. That's the area that we're looking at. A lot of these missed opportunities are due to either system factors or cognitive factors, and oftentimes it's actually a mixture of both. There's the interaction between system factors, so for instance, time pressures, your thinking gets interrupted, or there's just a pressure to see patients, and that's what leads to missing the diagnosis. You can't really have, you don't have enough time to get the history or correct history. And so we like to sort of focus on semicircle B. There are several cases, and I think that when sometimes the disease is very rare, it's really not possible to make the diagnosis in the outpatient setting, especially. And to a lot of the clinicians on the call, when you see patients, diagnosis is always an evolving process. Oftentimes, it's not possible to make the diagnosis when the patient first presents, but it evolves over time. And so we try to take all of these considerations when we measure missed opportunities in the outpatient setting. Next slide. So at the intersection of health IT and diagnostic safety, so we had a wonderful presentation earlier this, and I think technology has a lot of potential. So our goals when we started implementing health IT and EHRs were to help measure and reduce medical errors and improve patient safety, and that applies for diagnostic errors too. We want health IT to be used to measure and reduce diagnostic errors and related harm. But right now, what we're finding is it's really, we're trying to ensure the health IT itself is being used safely. So just for example, next slide, is the recent case that we had in Dallas, Texas, where the patient with Ebola was sent home from the emergency room. And so this is a paper that we wrote on lessons on effective use of EHRs. And I think the main point there is, the EHR is only a tool and not a replacement for basic clinical skills and critical thinking. And I totally understand there's, reasons why EHR interoperability and usability have to be improved. But this is going to require both sort of technical as well as non-technical approaches. And there's no replacement for things such as, face-to-face communication, especially in a complex environment such as the emergency room. So there are lots of lessons that we've sort of learned about using an effective use of health information technology that are relevant in this paper. Next slide. So diagnostic safety in the EHR era is really sort of complex, as some of the things that I've told you over the last few slides. Right now, we really want electronic health records that could support provider cognition and decision making, but it may not be happening fully. Besides innovation, there's several things coming in the way. Use of templates, copy and paste, for instance, which is quite rampant in EHRs. One thing I want to tell you, there's lots of sort of template-related issues that happened in the case, the Ebola misdiagnosis case. I would encourage you to read the paper. So sometimes these, using the technology and the human-computer interaction, if it's not effective, gets in the way of the diagnostic process. So we need to think about those things. Of course, there's problems with the reduced efficiency that can happen, the time pressures. There's also things to consider, our data display issues that could lead to ambiguity. We had a recent paper that is linked below in JAMIA, where we studied graphing patterns in electronic health records as how the graphs were displaying diagnostic test results, and there were several problems within the graph. I mean, we're talking about high school math here. So we really need improvement in those areas of data display, data visualization. We also have this sort of eye patient phenomenon going on, where clinicians are spending more time with looking at their computers and not sort of talking to patients. And we all know there's several reasons for that, but we think that there may be some effect going on in critical thinking skills. We also have electronic communication breakdowns that persist. So about 8 to 10% of test results that were communicated electronically were still getting lost to follow up, and no matter what system we look at. So there's several issues that have come up with the use of electronic health records. So as I said, technology is a tool. We need to now sort of figure out how to use it better. So if you go to the next slide, there are several reasons that we need to think about sort of new unintended consequences of technology that have become quite relevant. So we're having this alert overload phenomenon through EHRs, where lots of notifications and lots of noise in the in-basket, as what people call it. So there's a study we did where we found that about 30% of providers were reporting that they had missed abnormal test results because of information overload in the electronic health record. Go to the next slide. And you would know that more digital data is on the way. If you just keep ticking through this slide. So, for instance, the smartphone as well as wearables are going to bring more data, and people are, saying now patients can continuously monitor their data real time and send it to their doc. So we're going to have more data coming our way than what's just in the electronic health record. So we just need to be sort of wary of all of these issues as we go forward. So next slide, lessons from research. I think it's important to realize that I think EHR systems are better than paper, and certainly nobody's going back, but we're not achieving the full potential, and we're not achieving the full potential because of many of the things that I just described to you. We really do need socio-technical approaches to improve diagnostic safety. And what do I mean by socio-technical is on the next slide, is you really have to sort of consider, go to the next slide, please. You really have to sort of consider these 8 dimensions, and this is a model that we developed, when you consider improving, patient safety in the EHR era. And you have to really walk through those 8 dimensions. So it's not just the technology part, which is hardware, software, content, and maybe the user interface, but also think about the workflow and the organizational policies and procedures, the personnel. There's a huge influence of external rules and regulations, which you'll see on the extreme right-hand side of the slide, where things like what the Joint Commission says or what meaningful use, for instance, is a big influence on the way we use electronic records. So all of these things have to be considered when we design, develop, implement, and use health information technology. So as a researcher, I would say the academic contribution here is every one of these dimensions is important to the way we practice healthcare and improve diagnostic safety and reduce diagnostic errors. And so that's what we've sort of worked on in the last few years. Look at the next slide. So measurement of missed opportunity. So really, if you need to make progress, as I said, we need to measure diagnostic errors, and IT can help us do that. But also missed opportunities must reflect real-world practice. So it's not just only about the way the doctor is thinking and the way the differential diagnosis is happening, which is really important. But it's also about how the system and the team members and patients, how they interact with the clinician and what's the thought process going on. And so we really have to consider the system factors that affect the way the clinicians think. And I want to present to you a framework that we have sort of used in the next slide, where this could help push the understanding of this topic a bit forward. We call it the SAFER DX framework, where you have the dimensions of the diagnostic process on the left side, where you talk to patients, you order tests, you follow up that diagnostic information that comes back to you, you make referrals, and this all happens in the context of the socio-technical work system, and this produces measurements that are used to improve organizational learning, leads to safer diagnosis. And so again, it's a complicated diagram that I'm not going to walk through every bit of. Welcome to read the paper, but the point is we really need a broad framework in order to put the diagnostic process improvement on, as a candidate to improving patient safety, improve the value of care. And all of this happens within the socio-technical work system that I just sort of walked you through. We go to the next slide. And so we talked about triggers. So Mark mentioned, some of our work in triggers, and this has been really one foundational piece to some of the things we've done in measurement and reduction. And so this is the way the diagnostic journey happens in the outpatient setting, for instance, where the patient sees maybe a primary care provider. And if they have a certain correct diagnosis, that's great, but that often sort of happens infrequently. Usually you come back and make more encounters, or you're hospitalized, or you have a diagnostic test, or a referral, or a consultation, and then you get the correct diagnosis at the end. And this model really has been useful for us to develop triggers. And if you click on the next two buttons there to animate that, and the next one, and these are the places that we can sort of catch the problems when they occur. So if patients, for instance, make unexpected return visits to the hospital, or they get readmitted, there may be a way to catch diagnostic errors. At that point of time, we may be able to catch diagnostic errors and measure them in terms of diagnostic testing or consultations through other types of triggers. So this model has been useful for us to develop these triggers as we go forward. Go to the next slide. So what are triggers? Triggers actually are basically just algorithms. They're programs to help select some high-risk patients so that we can review their records further to look for missed opportunities. So what we've done is we developed these software algorithms. We run it in the EHR data warehouse, which is just a repository of all the electronic data that comes in from the EHR. And we try to identify patients who may be at more risk for a diagnostic error or loss of follow-up or missed results. And it's basically like picking up needles in a haystack by making the haystack smaller. And when I say that, it's, we're not going to be able to get all the patients who have diagnostic errors. We're not going to make this, perfect, but it's a way to kind of identify patients. Right now, we're not using any systems to identify patients with diagnostic errors or missed follow-up. So we're just trying to make sure that we catch at least some, if not all. The application of triggers could be either retrospective or prospective. By retrospective, it could be, sometimes when the patient comes in and gets hospitalized, you might can do a look back to see was there something that happened in the primary care visit or the emergency room visit that could have been, that may have been a missed opportunity in diagnosis. And that just is after the event. But you can also apply triggers prospectively. And this is an example I'm going to give you in the next slide. Is, for instance, if there's a patient who has an abnormal test where they haven't received their follow-up. So take, for example, a patient with positive FOBT, positive hemocult, who may not have had a colonoscopy in 60 days and were eligible to have a colonoscopy, but they still didn't. And of course, I'm giving you a sort of a basic platform of a trigger. But we make the triggers quite sophisticated so that we can identify the patients who are, get the most signal, right? So make sure the patients who are have not had, a test before, who are, of course, still alive within the right age group. So we build these trigger algorithms so we can identify the right cohort of patients, review their records to make sure that they are truly lost to follow up, and then we intervene. And when we intervene, that means we'll communicate this information to the provider saying, you may have a patient who has a positive FOBT and has not had a colonoscopy. And the same thing for a chest x-ray that may be abnormal. So there's a separate paper coming out in radiology where we actually went in and identified all the abnormal chest x-rays that were coded as suspicious for malignancy, but that had not received follow-up in 30 days with either a biopsy or a CAT scan or some intervention that should have followed the abnormal test but had not had the intervention. And generally, we find that out of every 10 records we'll look at, that the computer says these are trigger positive records. That means they are the ones who are probably lost to follow-up. About 5 to 6 of those 10 records are positive. That means when the computer says 10 are lost to follow-up, when we go into the medical record to confirm that, about 5 or 6, depending on the trigger, are lost to follow-up. And sometimes we miss things when, let's say, they had a colonoscopy at an outside institution and which was not recorded in our EHR. Then, of course, we're not going to define those patients. Go to the next slide. And so, this is a good technique, but is it time for putting this in practice? Well, it really needs resources and time investment. So we did this as a research project, and now we're doing more work in the VA to try to push this into the facilities directly. So we intervene as researchers, but I think the facilities or the organizations or the hospitals or the ACOs, for that matter, that are putting these systems in place will need to have consider the time, the resource investment to track these abnormalities and put them in practice. And it's sometimes hard to contact physicians. Some of you may sort of have realized, it does take time to get to the right person, and that has the problem in the outpatient. And sometimes in the inpatient setting, when you're trying to communicate abnormalities, you don't know who to call, it's not clear. And when you call that person, they say, well, it's not my patient, it's somebody else's. So all of those issues we faced. We could also have introduced some unintended consequences related to creating these surveillance techniques. People might, we might sort of induce hypervigilance. People might do unnecessary testing or treatment. So we have to just consider all these issues as we go forward. Next slide. So what do we do now? Do we have things that we can do now? Yes, of course we do. We really need to sort of do stuff now. We can't wait for our EHRs to be perfected. We can't have all the research evidence in the world talking about interventions. So there's some things that we have done over time. So there's just some papers that might be useful to help improve follow-up of test results, especially in the outpatient setting. If you go to the next slide, we've also developed these SAFER guides some of you may be familiar with. And there's actually a test results reporting and follow-up SAFER guide that I would encourage everybody on the call to look at, which has several useful practices for people to do. The ONC SAFER guides are freely available on the healthit.gov website. The link is at the bottom. But they are nice sort of self-assessment tools. They're not regulation. They're not certification or accreditation. They're just self-assessment tools that people can use in their practices to see if they are, doing the right things for things like test result follow-up. We also have one on communication that people could look at. Look at the next slide. I think this might be the final slide. I think we need really to leverage health IT to explore, understand, and reduce diagnostic errors. And there's plenty of tools and strategies people could start using. And as researchers, again, as I mentioned, our goal is to improve the evidence base and to improve the scientific foundation in order to do that. And so the last few years have been quite busy for us in doing such things. So I really want to thank my funders. In the next slide, I have my contact information, but the several funding agencies that have contributed to all of this research that I hope would be very useful. Thank you.
Thanks, Hardeep. Enjoyed it. So we have time for two quick questions. This one is from Mark Tenenbaum. You talked about test results that are missed or lost to follow-up. Can you give us an idea of are these really a system problem where things get misrouted, or is this a physician error where the results are overlooked or never looked at?
It's actually both. We found all sorts of things. So there have been instances where the clinicians have known that there was an abnormality but didn't follow it up, and the reason we found out was because they thought somebody else was following them, the abnormality up. And this is a typical when, let's say, a pulmonologist orders a CT scan and might think the primary care doc who referred the patient to them will follow up, and the primary care doc thinks, well, I sent the patient to a pulmonologist, and of course they're the ones who are following up. And diffusion of responsibility is a huge thing as far as follow-up of test results. But we also see systems where there's no tracking system for test result follow-up abnormalities, and we get routinely get results routed to the wrong person, or there's an IT problem where there's a configuration issue and the computer doesn't deliver the result to the right person either. So it's a mix of everything.
Thanks, Hardeep. And this is a follow-up question from Mark. Where are we at in health IT in regard to being able to filter the data so that the most salient, the most important data gets noticed by the physician?
We're far away from that. I'm not sure in what context, but if you're thinking of progress notes, it's a different story. As I mentioned earlier, there's a huge issue with progress notes right now. We've looked at progress notes which have so much clutter and there's just not enough signal. If you were thinking in terms of test results abnormalities, we're getting a lot of stuff in the in-basket right now from all sorts of places. So referral information, triage notes, pharmacy refills, physician messages, nurses messages, everything comes within the in-basket. So we're in the thing that, and the test result abnormality with the abnormal chest X-ray might get missed just because there's so much other information. So I think we're far away from filtering the right information, but that's a way.
I agree. And one final question, it's kind of a philosophical one. This is from Jorge Ferrer. You talked about unintended consequences. What about the burden of data entry and working with the EMR? How does that interfere with developing a rapport with the patient that's right in front of you during that clinic visit?
Yeah, it does. It interferes. In fact, one of the commonest complaints we now receive is, the doctor didn't look at me at all while they were talking. So I think a lot of the clinicians are finding ways to sort of engage the patient within the conversation and have the screen sort of facing them and showing them some of their notes. And of course, there's a lot of movement on open notes and improving access to patients looking at their own notes. So I think that we're going to have to do things differently because the interaction, the doctor-patient interaction, is suffering quite a bit, and that's what happened in the Ebola case too, which was very prominent.
Yeah, I agree. Thank you so much. We're going to move on to our third speaker, Dr. Michael Cantor. The next slide, please. Michael is the Medical Director of Quality and Clinical Analysis at Kaiser Permanente, Southern California, provides care to 3.5 million members of that healthcare system. He supervises all the quality measures going on in that system, including HEDIS, JACO, Leapfrog, many others. Michael has a wide range of interests in regard to quality and safety, but we invited him today to tell us about the work he's done with the Safety Net program at Kaiser Permanente, which has the ability to catch diagnostic errors before they cause harm, and to do this on a large scale. The title of his presentation is Using Health IT as a Safety Net for Diagnostic Errors. Thank you, Michael.
It's great to be here, and I am going to why don't we just go to the next slide, and I'll start talking. So there's lots of types of diagnostic errors and causes for them. When I initially started on this journey that I'm going to describe, I was mainly focusing on failure to follow up abnormal tests, and the reason I did that is because I think it's the easiest thing. It's not something sitting in the physician's head or cognitive processes, and the clear paper trail that's left on electronic records. Having said that, what you'll see in here is some foray into some of the more cognitive errors, and I'll give you an example of that. And we've done a little work in visual diagnosis errors as well, but I'm not going to talk about that. So let's move to the next slide. And what we created is what we're now calling a SureNet. We used to call this safety net, and it was getting confused with the various outside providers that care for the uninsured and indigent. So it is now officially called SureNet. I may lapse back and forth. What we created was a program that we're one large region, 13 hospitals. It systematically looks through the medical records to find patients with lapses in care. We have a small team. It's up to about 6-7 people that actually reviews the data and then tries to intervene before harm reaches the patient. When you're dealing with ambulatory safety issues, you have oftentimes the luxury of long times between when the lapse or error is committed and harm actually reaches the patient. And the way we make this scalable is make as much of it electronically done as possible. When you get into manual chart review, you very quickly lose the ability to scale. I might mention that we started this journey from a safety point of view rather than a diagnostic error view. So this SureNet functionality covers other things other than diagnostic errors, and maybe we'll go to the next slide, which should be showing our current portfolio of activities. I've rather arbitrarily lumped them into diagnosis, detection, and follow-up, and medication safety. Some of our earlier forays into this were medication-related, like people taking too much Tylenol without any doctor particularly realizing it. But the process is the same for diagnostic issues, and we've got, I haven't actually counted them up. We launch about one new one every 3 to 4 months, and I'll talk about how we do that. It's a little bit arbitrary what is medication safety versus a diagnostic issue. So when you get into things like monitoring people on diuretics for electrolyte abnormalities, that could be viewed as failure to diagnose hyponatremia, or it could be viewed as a medication monitoring issue, and I'll leave that to people's philosophies. The more diagnostic related ones are on the left. I'm not going to go through them all, but we'll kind of highlight a couple typical examples of how they work and what we do. Just a couple comments. Some of these are sort of mixtures of things. So when you get into things like aortic aneurysms, some of those get missed because nobody reads the radiology report and sees the aneurysm in there because maybe it was ordered for a totally another purpose. And some of that is people with known aneurysms and they just didn't get followed. So these are not necessarily pure diagnostic issues, and there's all kinds of hybrids. So I hope that is clear to everybody. What I was going to do next, if we go to the next slide, is actually describe how some of these are constructed. just to give you a sort of a flavor of what we're doing. And so key element is it's got to be mostly electronic. We created a PSA safety net. The reason we did was because we were getting litigation on the subject. We cover our own insurance. We're essentially self-insured, getting a couple of these a year, and that shouldn't be terribly surprising out of 3.5 million members that these would happen. What we found is there'd be elevated PSAs. They didn't get followed up. Patients would present later with prostate cancer. And when we started looking at these, everybody thought they were going to be subtle abnormalities of PSA velocities missed or barely things above the normal range. And what we found when we went into the charts is these were people with PSAs way, way above the normal range, 10 or more, and just not followed up. No documentation in the chart as to why they weren't followed up. Doesn't do well in a courtroom, as you might imagine. And so this is one of our earlier ones. The way this works is we actually go through our records, find everybody with a high PSA, and then we electronically filter out those that we know are probably okay. So if they've already got prostate cancer, they're removed. We then remove people who have had appointments or are scheduled to have appointments in urology, oncology, or radiation therapy, take out people on hospice and palliative care, and it's the remaining folks that actually fall into the safety net. Now you'll notice that we're making some assumptions here that if somebody gets into urology, they're managed properly. And we have to do that merely to make this thing scalable. So, and I think Hardeep mentioned it, we're sort of narrowing and making smaller the haystack, but not necessarily finding every case and doing it with 100% specificity. So if we go to the next slide, this one does require some manual chart review. We always on these things collect some outcome data. For this particular one, over 3 years, we found 8,000 patients that needed some kind of manual review. We have some prostate cancer case managers. They reviewed these charts, gave appointments to, and when there were questions, they'd contact the primary care doctor, gave 3,800 urology appointments out. When they got in urology, 2,200 underwent biopsy. We found 745 cases of prostate cancer. And since this program has been in place, we have not been sued. Couple points here. Can't tell you if these patients are better off with their prostate cancer or not. And we can't really know for sure how long they would have gone forward undiagnosed had we not intervened. There's no control arm in this, but we like to capture this kind of data to just make sure we're at least detecting abnormalities and the program is working. Another example, if we go to the next slide, is chronic kidney disease. Similar program. We look in our computer systems for patients with high creatinines that have not been repeated after 90 days, and the official criteria for diagnosing CKD is to get 2 elevated creatinines in a separated by time. We eliminate all of the patients that are known to have chronic kidney disease. What's left, we actually pended orders into the physician's in-basket. If the physician, an order for a repeat creatinine, if the physician signs the order, we send the patient a letter telling them to come to the lab. We got roughly 7,000 labs repeated, and out of those, roughly half were noted to have CKD. We could also debate on this one, is this helping patients or not? We're actually doing further studies on this, and these findings should be published shortly in a journal. It's not out yet. So let's go to one more. Both of these two well, I'll get into, they're really about follow-up. This one has to do with rectal bleeding and is more cognitive in nature for the most part, although some of this is lack of follow-up. And we did a chart review of patients with advanced colon cancer, a diagnosis, wondering why they had advanced colon cancer. The most common reason is they weren't screened for colon cancer. And the second most common was there were symptoms that were not followed up. Rectal bleeding was one. So we created this program, basically people in this age range, not in hospice, who haven't been screened for colon cancer, didn't have CKD, the GFR was normal, and had a history of rectal bleeding, which we captured from these codes. And we looked for whether they had a workup. And if you could go to the next slide. The next slide should show that we found 168 patients. It's tough to get these patients in for colonoscopy, but we got 26 in so far. We did find one adenocarcinoma with a metastatic lymph node, and we found another carcinoid tumor, and then several adenomas. So I think this did identify some pathology that otherwise would have been missed, particularly the two tumors. Key to note is the difficulty in getting the patients in for colonoscopy, even once we find out that there's a reasonably good indication. So those are the three I wanted to cover. I have some more slides if we can go to the next one, and sort of wanted to talk more about the philosophy of this and how we've organized it. These is a sort of speculation. Why aren't these results followed up on? The amount of lab testing and X-ray and other testing is massive, and just having a 6 sigma reliability even then would have fallouts of things that fall through the cracks, and I don't think our doctors or any doctors are anywhere near a 6 sigma level of performance. There could be issues with formatting of results, lack of systems to manage the results, and I think every doctor has their own kind of system. A key point is the patient is a part of the system. So some of these lapses or lack of follow-up may be patient-related. I think that's definitely true for the need for colonoscopy, and many of these patients simply refuse, and it may not always be well documented in the chart, why things don't happen. We have noticed that the electronic records don't solve the problem. Our PSA safety net started before our electronic record, and we're still having cases fall out at more or less the same rate, although I haven't subjected that to analysis of any rigor. Obviously, handoffs between doctors, and I think Hardeep alluded to some of these issues. So we really need to actually understand better why these things occur, and we're hopefully going to be starting some research projects to look at that, given that we have a method to actually measure the rate at which patients fall into our SureNet process. Next slide. I just want to make this clear. We're in an integrated delivery system. We've got all the records more or less on our patients. So what I'm showing here is how we do things. It may not be the way everyone else would, and I think the issue really is use whatever data you may have in your system, but I think the general philosophy is generalizable. It's just the details of how to do it will be different. Obviously, discrete data is best because it's easiest. We struggle with radiology more than lab data because of that. And also the last point, if there's office staff in the physicians or existing case managers that have some bandwidth, it is good to use those folks and take advantage of them. Next slide. This is kind of how it's set up to get the throughput we do. Ideas come in from a variety of sources. A big one now is actual physicians who have had near misses and realize that we can help them out. Once ideas come into the SureNet department, they get reviewed by leadership to basically just approve the basic concept. We convene a group of subject matter experts that are really more frontline clinicians who would be impacted by this to make sure whatever we construct would fit in with their workflow, not annoy people, be reasonably user-friendly. Once they meet, they develop the detailed specifications, goes through another approval process. Before we deploy it, we get a physician champion who will advocate for it and send out communication to all of the physicians. And lastly, we launch that. So this entire cycle can be done reasonably rapidly, and that actually is the key. Culturally, we want it so that as people report issues, they see solutions come out, and it doesn't just go into a black hole. Next slide, and I'm going to have to, I think, skip a few things. Let's skip this slide. Next slide. There's some big cultural issues. Go back one more. Yeah, we take a blame-free approach. We're not looking at why these mistakes are made. Again, that's labor-intensive, doesn't allow for the rapid development. Frequently, it's documentation issues, and so we want to encourage people to come forward with their ideas and misses. The other issue is, and that's how we rapidly build these things, is people actually like them and find them useful. The other key cultural issue is transparency. We have had to go back many years and inform patients that they didn't get followed up properly. We make no attempt to hide that. We go back up to 10 years on some of our programs. Very difficult conversations sometimes with patients. Next slide. Key issue to make this work, and I alluded to it with our subject matter experts, is we don't want this intrusive into the physician's practice, so we generally favor specificity over sensitivity to decrease the sort of annoyance factor. We do as much as possible for the doc, so we'll notify patients if they need follow-up rather than the physicians, particularly for sort of minor blood tests. Get buy-in and all of that before launching the thing, and I alluded to that. And next slide. If you need justification with a business case, focus on the stuff that decreases malpractice litigation. Usually those are the cancer-related ones. Minimize manual review of records, and we assess all of our programs so I can tell somebody how many things we're finding, and that usually is very motivational, even if you can't put dollars and cents around it. And next slide. There are some problems notifying patients of things that happened 7, 8 years ago. We've had this with both creatinine and hepatitis. They're not necessarily happy. You just need skilled nurses to deal with this. Sometimes physicians need to get involved. Some doctors will get upset if you falsely inform them there may have been a problem. And likewise, the staff managing both the upset physicians and patients may need some support. I would mention, though, that it's a very small minority of people that get upset with these things. Most people understand what we're trying to do, why, and actually are very appreciative. It's that 1% tail that one should be prepared to deal with. And next slide. And I think we'll actually be done here. Yes. I'm going to actually just stop here. I don't have to read the summary slide. But for us, this has been a useful program. Our next steps will be trying to better quantitate some of our findings and put it in more of a research context, but we've taken a more pragmatic approach to just try and get out things quickly to make things safer. So any questions would be appreciated.
Thank you, Michael. And if it's any consolation, you're not the only one who's going to have trouble remembering to call it SureNet instead of the Safety Net program. So a couple questions. We have time for a few. Can you give us an idea of how many other healthcare organizations are starting to do something similar to this? Is this starting to get out there?
I would actually say everybody does it to some degree. Just about every doctor has some tickler file or something to alert them when they miss something. What I see different here is this is systematic over a large group and it's uniform, but I think doctors have kind of on index cards and other things been trying to track follow-up since Hippocrates' time, I'm going to guess. We're spreading it throughout the other Kaiser regions. I don't know how many I've had a lot of calls from people interested in this, and I'm happy to talk to anybody, but I don't have a great feel for where people are, and like I said, it's not an all or none phenomenon.
Yeah, we've had a whole series of interesting questions from Mark Tannenbaum. I'd like to just tackle two of them. So the first one, if I can paraphrase it, the SureNet probes, are so well designed to detect quality and safety issues. Can you also use these, or have you used them to detect trends in certain provider practices? For example, to find providers who are over-ordering tests with low diagnostic yield?
We do that, but it's not part of this program. What I thought you would ask is, have we looked for trends among doctors who consistently have cases fall out, and we're in the process of doing that for 3 of our programs, and my sense is they're pretty uniform distributed, but I don't know that for sure. All of our, we have a huge ability to monitor test ordering now.
Thanks. And one last question, and it has to do with the measles epidemic that recently started at Disneyland. Can the SureNet program interact with, for example, the state vaccination registry to see which patients still need vaccination?
Yeah, again, some of this is nomenclature. We actually went through our database and sent out somewhere around 70,000 letters to pediatric type patients informing them they need a measles shot. I don't know how many actually came in. We haven't captured that data, but that actually, I guess you're correct, that would be kind of similar to this program, and we did do that.
Okay, well, let's call it a day. I'd like to thank our 3 speakers. It was an outstanding presentation from everyone. I'd like to thank all our listeners for your time and for your interest in diagnosis and how it intersects with health IT. And I'd like to turn the program back over to Michael for any closing comments.
Thank you, Mark. Again, an excellent presentation by all of our presenters. I just want to remind our listeners we have a planned webinar for June 18th on the topic of EHR usability and health IT safety. And again, thank you very much. Hope to see you at the next webinar. Bye-bye.